once you finish medical school, you're not allowed to practice medicine. You can't get a license to practice anywhere in the country.
We need to make this clear. You can get an MD after 4 years. So you're technically a doctor. You can say, hey, I'm Dr. Gerber. You're a medical doctor. And you can work zero.
You can never take care of patients, right?
Hello. Welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is a returning physician, Ben Gerber. Welcome to the show, Ben.
Thank you, Gil.
Ben was one of our first interviews. We talked about general surgery and trauma and all kinds of exciting stuff. And you were so popular, we've decided to have you back. And we could talk about a million things because you are a board-certified general surgeon. And me being a board-certified reproductive endocrinologist, we could just shoot the shit for days and days. But what I'd like to talk to you today about, Ben, is something that maybe should get a little more attention. There is a shortage of physicians in the United States, perhaps around the world. And we're using what are called physician extenders more and more, advanced level practitioners, very smart, very important people that we're all very happy to work with. But there has been a creep of people calling themselves doctors that the lay person, the normal public person would say, wait a minute, you're not a real doctor, right? And this can lead to confusion and maybe some misrepresentation. So what I'd like to talk to you about today is how does someone become a board-certified doctor, not just somebody with a medical doctorate degree or a PhD or an EDD or whatever doctorate or an OD. These are all people with doctorate level degrees, but they wouldn't be what you and I, what most people would consider an active practicing certified doctor to treat my advanced medical problems. So let's talk about how did Ben and Gil become a board-certified doctor that somebody can trust and go to for advanced medical problems?
I think this is a really important question, frankly, because it's just like all good things in life. If you have bad information in, then you will make bad decisions. And one of the key things as a doctor is I feel like there's this onus on us to provide good information to people that takes into consideration all of the various things that, with as minimum of bias that we can have about what we should advise people to do. And that my training and my personal experience as a physician for, quite some number of years now allows me to provide a very well-informed opinion about a recommendation to a patient. And I think it's really hard for patients and people who might not even know the right questions to ask, might not be able to suss out whether or not the person who's offering them advice really is qualified to offer that advice.
Yeah, I have patients all the time come to me, well, my doctor told me this, my doctor told me, and I know this person, they're very smart, they're wonderful, but they're an advanced practice nurse or a nurse practitioner or a physician assistant, yet they're calling them doctor because they're in a white coat and they're in the medical field.
And there's also, people who call themselves doctors who aren't necessarily even formally medically trained in how to care for patients.
Yeah.
I've seen, a doctor of naturopathy, for example. I have no idea what that credential is, but it's a very different thing than an MD, and that we should be really careful in how the patients are able to think about the advice that they get from, the different kinds of people who might be advising them about their health.
Yeah, in the world of infertility, Ben, if you go on YouTube, there's one person in particular who calls themselves doctor, and they give infertility advice, and I believe they're a doctor of acupuncture. Now, I believe that's a wonderful degree, and maybe he's a fantastic acupuncturist and helps a lot of people. But to call oneself a doctor and then give advice outside of your field of expertise, I feel is just misleading.
Right. I agree. I think that we should... And it's kind of, we need to be a little bit careful as professionals about what we're willing to talk about. Like I run into this all the time where patients are in my clinic and they're talking to me about their GERD or their hiatal hernia, and they're also seeing another host of other doctors, right? You know, you've got breast cancer and you've in surveillance, and you know, like, well, they're gonna, and they ask me a question about something related to their oncology or their chemotherapy, and I'm like, I don't feel comfortable advising you about whether or not the advice you received from the other doctor was good advice or not, because, well, they're more knowledgeable about their area of expertise than I am, and I'm not going to like overreach my education and my what I really know and try to offer you some advice shooting from the hip, guessing about what I don't really know about. And it's just going to give you bad advice and ruin your relationship with the person who actually should know.
Yeah. So in order to get here, Ben, how does one become a board certified practicing physician? It's a long road to hoe, isn't it?
Yeah. I mean, for me, and I think for most people, it's, you know, you do 4 years of college after.
All right,
you know.
so you got to do college, and there's all this attention on your GPA, on what kind of grades do you get. That still matters, doesn't it?
Absolutely. On the pathway of getting to become a doctor and becoming a board certified practicing physician, there are various steps along the way that have to be completed. But if you do some studies to look at, like, well, you know, where do most people fall out, right? What's the fraction of people who apply for medical school that actually get into a medical school and matriculate into med school? And then after they graduate med school, what fraction of those people actually get into a residency? And what fraction of those people become, you know, get into a fellowship, or who become board certified practitioners? And if it looks like after you get into medical school, almost everybody will go all the way through unless they have some sort of horrible disaster in their life. So that's
the big cut.
The big cut happens when you get into med school.
All right, so you're in college. So most people, and Europe, I know that the tracks are a little different. We'll talk about the United States. So most physician candidates are going to do 4 years of college or more, and maybe some grad school.
And there are a few programs that have an integrated undergraduate medical system, like Kansas City has one.
We still have these 6-year programs. I know they've fallen into disfavor, but for because they figure, you know, what is a 17-year-old kid doing making the decision to become a doctor if they still have to do college? And some do. Right. Some
very
kids
driven people may be able to make that decision. But
that's right. But for the most part, there's going to be at least 4 years of college, and the person's going to have to study something biologically related or science related, but not necessarily.
Not always, right? Yeah.
I know. I've seen doctors who studied history.
Yes.
History or philosophy. And there's nothing wrong with that, but there's going to still have to be some biology, some chemistry, and some physics in there.
Yeah, typically they have like pre-med requirements. Like most medical schools will say that you will have, I mean, even if you didn't major in, you know, chemistry or biology, you have actually taken these particular chemistry and biology classes as prerequisites for your application into medical school.
And one of the famous classes for weeding out is organic chemistry.
Oh, yeah.
Yeah, there's bumper stickers about that and P-Chem as well. Yeah. But that's the real, that gives you some idea right off the bat who's going to be the doctors. There's those that are really digging in and doing okay in organic chemistry. That was a big one. I remember
organic chemistry.
Yeah, you were organic. Yeah,
we had this teacher.
Fondly or not? Yeah, tell me. Please tell me.
It was funny. I mean, we had this teacher. She was pretty short, and she was a super high energy woman. And she had this like coffee mug that was this big around and like this tall, and it had the Tasmanian devil on it. And she would bring in this thing, and she'd like set it down. And this was back in, I mean, this dates myself a little bit, but back in the days when there was still a chalkboard. Right. So, and we had this lecture hall, and organic chemistry was, you know, so there was a relatively big lecture hall. So there was probably, I didn't go to a huge college, but it was maybe 100 kids in there.
Yeah, there were 120 in mine, I believe.
And she had, the lecture hall had 3 blackboards, and each blackboard had 3 boards in it. Like they were like,
they'd slide up.
So she would start on what she had this giant sheaf of paper, and she would start writing. and then she would go across, and then she would go, like all, and then she would fill the other board and the other board, and then she would just throw that one up, and then she'd keep going, and it was, we had these, I was like spiral binders, right, and you just try to keep up with her while she goes.
Yeah, and you're thinking, if I don't ace this class, I won't get into medical school.
Well, I mean, when I went through college, I wasn't planning to do med school, but I was a science major, like I was interested in science, and I was planning to be a researcher in a lab.
Right.
But yeah, I mean, it absolutely, you're like, this is this kind, and she was just, which the Tasmanian devil thing, which just moves so fast because she was like, we have so much material to cover, and then she just take off, and I was just like, oh my.
So pre-med, it's not easy. There's a lot to learn.
Yep.
And I know some colleges or universities have more prestige than another.
Sure.
And I think in the past, they think, well, maybe we need a test to kind of equalize, because people like to use the word Harvard. I'll use Michigan, a school that's reputation precedes it. But if you're in some small schools somewhere, I think people figured out, well, maybe we should have a standardized test,
right,
that you can also take, and it's been called the MCAT for many years.
That's right. So the MCAT it's still, as far as I know, still in use, and everybody who wants to get into med school has to take the MCAT.
Something like medical college admissions test, maybe that's what it stands for?
Yep, I think so.
Okay. So the MCAT. So we have to take an MCAT too, and there's prep courses. In fact, I used to teach at one of these national businesses that teach how to take the MCAT. I used to be an instructor how to take the MCAT. So that's another hurdle. It's like the SATs after high school, right?
It's a little more intense. I remember having studied a lot more than I did for the SAT.
People paid big bucks to this school for me to teach them.
Books that you would go through and question banks that you would
go through. I remember spending a whole summer in college. I spent the summer in Ann Arbor going to the same business that taught these things and doing it hours and hours.
You send out your applications, and part of the thing that's so difficult, is that if you put yourself in the shoes of the people who sit on the admitting committee at the university. So let's say
the medical school.
At the medical school,
right?
So you're at the medical school. Imagine you were sitting on the admitting committee. Like, you've got maybe 150 med students that you're going to take this year. You're going to get at least 10 applicants for every one of those positions.
So you got to go through 1,000 or thousands of
each
applicants.
Applicant is going to have like a 20-page application. Right, so just add up the pages, right? You're going to be looking at like 1,000 applicants who have 20-page applications. You're looking at 20,000 pages of applications that you're going to have to review, and so like it's literally impossible for an admissions committee to read all of that. And then, you have to, so usually what they do is they make some sort of relatively arbitrary criterion, and they say, well, if your MCAT score doesn't meet a certain criterion, we're not even going to read your application unless someone knows you. Like if you somehow know somebody, or somebody, like you did an internship in that guy's lab or whatever, and like somehow you're connected to that school in some special way, or they can pull your application out of the pile and give it a little bit more special attention. But they usually have to create, it's just because of the nature of the problem to review all of these applications, you can't realistically read them all. So they have to sort of slice it down to some manageable size.
Right. Right. So they'll draw a line on the MCATs, they'll draw a line at the GPAs or whatnot. And this does happen. If your daddy did buy a $100 million wing to the hospital with your name on it, they'll probably look at your application a little bit. That's life.
And that's where, people talk about, well, how do you get into medical school? And to a certain extent, it's study hard, but there's lots of these necessary but not sufficient components. Right? Mm-hmm. You can't bake a cake with only eggs, right? You have to have all these other pieces. So you can't get into medical school with just good grades.
Right.
You have to also have these other components. And, one of the things that's really quite useful is if you have some kind of specific relationship with the people who are educators. Like maybe you've done shadowing experiences with the doctors who are part of the medical educational program at that hospital, right? So you're applying to University of Michigan, and you've done you did a summer internship in the lab at the University of Michigan, or somehow met some of the doctors there and you got a letter of recommendation from one of them there or something like that. And that's where those experiences can actually be quite directly useful for you to get into that. Maybe you served as an aide in one of their, on the floor of their medical floor
Yeah, I remember getting advice as an undergrad, and the advisor happened to be at Rutgers Medical School, where I ended up going. He said, "How do you know you want to be a doctor? How do you know you like being in a hospital?" He said, "I want to see some time in a hospital, doing some kind of hospital job." And I did find one, and it was important because I knew that some wards didn't smell very good,
Yeah.
And some people did. It wasn't something I necessarily wanted to do, but it was very, very valuable. So to summarize this, you got to do a lot of work as an undergrad. You got to do really good on your MCATs. Got to get recommendations, and hopefully you've made the cut, and you can get admitted to medical school.
Yep.
And I don't know what the numbers are, if it's 10% or 15%. I think historically it's something like that.
When I was
get admitted.
Yeah, I don't remember. When I was applying, I remember it was around 40% of people who applied would get in somewhere.
Would get in somewhere.
They would get in somewhere. Not necessarily that they would get in at the place that was, the top choices or whatever, but they would eventually get into medical school somewhere.
Right. And as an aside, by the way, veterinary school is even tougher. It's harder to become a vet, by the way.
And it's an incredibly difficult job.
Yeah. So
I have a lot of sympathy for those guys.
I do too. And, all these advanced places, that there is a cut and whatnot. So we can certainly be fairly well assured that if your physician... if your physician is treating you, they probably did well as an undergrad and they made the cut to get into medical school. So let's talk about medical school. What does that entail?
So almost all medical schools are 4 years, and your 2 years at the beginning are usually mostly didactics and educational stuff like lectures.
Classroom. Is that still, that was the truth for me. Is that still true? You're a little younger than I am.
So I went to MU for medical school.
Missouri.
University of Missouri. And at MU, they have what they call the problem-based learning program, where there's a relatively diminished emphasis on classroom lecture type education. And they have small groups that break out and they work with a faculty supervisor, and then they would go through these carefully designed case examples where, the faculty guy would hand out to you guys like a page, and on the page it says you have a 45-year-old patient who shows up in the emergency department complaining of abdominal pain. And, it's a female and she's been having weight gain and swelling in her ankles. So then you're like, well, then you guys, when you start as a first-year medical student, you have no idea what any of this means, right?
Right.
So then so let's examine her in these ways, and let's request these laboratory tests, and so then you try to examine, then he hands you the next page and says, okay, so this is your lab results, this is your whatever.
That sounds better, because my first 2 years of medical school were ass in the seat, lectures all day, and tests. It was traditional school for the most part.
So I really liked the problem-based learning. It worked well for me as a slightly older person going through med school because it was less. We still did some lecture work. Some stuff really needed to be in the lecture environment, but we did augment this stuff a lot with problem-based learning. And then after you finished your second year, typically you take board step 1.
I forgot about that part. Yes.
So the board, what is it? The MBS.
It was the science, basic information.
There are 3 board exams that you have to pass in order to be eligible to apply for a license to practice in any state in America. So you have to pass board step 1, board step 2, and board step 3. Typically, board step 1 is taken at the end of your second year in medical school.
Okay.
After you've finished your basic education, your didactics. And it's a lot of sciences and pathophysiology and diseases and disease management stuff. And then board step 2 is supposed to be sort of an examination to determine that you can communicate reasonably well in English to, American patients, and that you can perform appropriate physical exam, choosing how to do a physical exam appropriately to diagnose the problem, and that sort of thing.
So third year of medical school, at least traditionally, is where you did your required rotations. You do a big chunk. I think I did 12 weeks of general surgery, 12 weeks of internal medicine, and then maybe it was 8 weeks OBGYN, pediatrics, psychiatry, something like that.
And every medical school is going to have their own like mixture of various required rotations and how long you're going to be on them and all that kind of stuff. And that's correct. That's still in.
So most medical students are going to see the broad spectrum of the basic foundational medical specialties.
Yes, and the part of the value of that is to help you decide what kind of residencies you're going to want to go into.
Yeah, because you dip your toe in the water.
The next phase after you finish med school is going to be to get into a residency training program.
Yeah.
Because once you finish medical school, you're not allowed to practice medicine. You can't get a license to practice anywhere in the country.
We need to make this clear. You can get an MD after 4 years. So you're technically a doctor. You can say, "Hey, I'm Dr. Gerber." You're a medical doctor, and you can work zero.
You can never take care of patients, right? And
take care of patients. Now you can go into business.
You could go into business.
You can start a business. You can be a consultant.
Right, sure. You could work for an insurance company.
Go get an MD, PhD.
There's
MBA.
all kinds of things you can do with an MD.
Yeah.
But you can't get a license. So when it really comes down to it, the thing that really, really matters is, does the state allow you to get a license to practice medicine in their state? Okay.
Yes.
So that's what's going to finally come to the very end of this. At the end of the training, this training
be
program,
a real doctor.
Right. That's where you actually get to take care of patients, is if you have a license to practice medicine in that state. And then connected to that, and not necessarily required, is whether or not you have board certification in your specialty. And that's where we'll eventually get to.
Yeah.
But first you get into med school, then you finish med school, and your first 2 years you take board step 1. Your third year, you do your clinical rotations, which basically helps you decide what specialty you're going to go into. Are you going to be a GYN specialist? Are you going to be an internal medicine doctor? Are you going to be psychiatry, pathology, whatever? So that helps you make your basic decision about what you want to do. And then your fourth year of medical school is primarily taking board step 2, which is that clinical skill set examination. And then it's also going to be helping you polish up your application process for residencies.
Yeah, and you can rotate. You can go out. You can go to different cities. You can do away
rotations. You can do extra rotations in the area that you're going to apply into for residency, so that you have more letters of recommendation and more personal direct experiences in the area that you think is interesting. Yeah. So that by the end of fourth year med school, you do the match. Okay, so the match.
What is the match, Ben? Other than a horribly stressful, nail-biting experience. Explain the match.
So the match
please.
Is it's organized by a national organization that essentially uses a standardized application process for residency. And everybody submits all these applications to all these residencies, and then you go to those. They accept your application. You go there and interview, and then every place that you've interviewed, you will create your own what they call rank list. So it's like, this is my first choice and second choice and third choice and fourth.
So I'd really like to go down to the last one. Well, I'll take it.
Kind of thing.
I'll take it.
And then the residencies do the same thing, where they reviewed a bunch of applicants, and they basically go down their list and they say, these are the people top of our list and bottom of our list, and so on. And there are often, they're looking at your board scores, right? They want to know, how did you do on your board exams? Are you going to do well on your, what we call in-service exam inside your training program? So if you're in surgery, they have a exam that you have to take every year. And if you did really bad on your board exams, there's a suggestion you might not do so great on these things.
Right.
And so eventually you have to pass those to get all the way through, right?
So there's this formula in this system,
and
where you rank your favorite programs, they rank their favorite applicants, and it goes in the computer, and bam,
it spits it all out.
I mean, there's your matches.
Because previously to this, when you did interviews, you would travel interviews, you would have this high pressure situation where the residency program director would offer you a contract
right there. I know, right there.
Before you leave, sign here.
Right.
And they would put all weird, like, well, you get a membership in the country club. They would put
we'll
stuff
give you an apartment. Yeah,
right. They would do whatever they could to get you to come and stay if they thought you were any good.
And you're thinking, shit, I'm interviewing at Harvard over here. I'm interviewing at Stanford next week, and what do I do?
And I want to see the other place before I decide if I'm going to do this now. And so the match was the sort of solution to this, by creating a program where everybody could do all their interviews and then make a decision at the end. So then, once the match is finished, then you go off to do your residency. And depending on what you went into, residencies are 3 to 7 years.
Yeah, now let's finish up on the match here. So there is a match day.
Yes.
Where it's like a celebration. It's a big party. Now, for those that did not match, there's always a handful that don't match for whatever reason.
Yep.
Now, and you would find out, you should have an advice
like
about
days,
a week,
3
day, like kind of the week before. It's like, no, I didn't match. And that's when that's when the phones would go on. And your advisor.
So they have a different process now.
They have a different process. Well, it used to be they'd get on the horn.
Right.
So you want to be a psychiatrist? Well, and by the way, that was when you'd always match. And nobody wanted to be a psychiatrist, or for so few, there were more spots than applicants. But let's say it was a very competitive residency. Joe would get on the phone with Jane over here and say, well, I got a slot and blah, blah, blah. There'd be this horse trading going on. So at least on match day, you could go in and with save face. You'd have your envelope and you'd know where you were going. Yeah, but match day is a big deal because for most, you matched somewhere.
Yes. But you don't know where it is.
You don't know where it is.
Until match day.
And it's like...
You literally give you the envelope.
They give you literally...
Like, I'm going to Philadelphia.
Right. Yeah.
And then you'd be there for years. I mean, and...
it's a life-changing event.
3 to 5 or 7 years of your life in a particular destination. And now they call it the SOAP. I don't remember what it stands for, but it's a mechanism for them to redo the match for people who didn't match in the primary match. And I don't know exactly how. They used to call it the scramble, but
scramble. It was a scramble, right?
It doesn't exist. The scramble isn't really in existence anymore. Now they have it called the SOAP process. And I have not, it's been, that changed after my era. So I don't know much about how the SOAP works. But nonetheless, like after you match, you go on to a residency. And if you go into family medicine, it's 3 years. If you go to neurosurgery, it's 7. And then everything is sort of various different degrees in between. All the other stuff.
So here you are a doctor, but you're not yet a doctor.
Right. So I mean, you're a doctor, and you have an MD, and you apply for, and you get a license as a trainee license from the state.
Right. So they know you're usually in a hospital in a residency. You're supervised, and you get one of these provisional or trainee licenses.
You have to. All of your notes and your orders and everything you do has to be approved by a supervising physician as a trainee. So you're not allowed to
make big decisions.
Go moonlight, as a trainee.
Right.
Like that was a thing that moonlighting is a thing that used to be in existence, but it was basically where you would conduct your, residency training, but if you had spare time, you would go work at the other hospital across town.
Right. Once you were a senior resident, or for me, it was when I was a fellow.
Right.
I had passed I was a fully licensed physician, and then I could work at night in the inner city or whatnot, and it doubled my income.
It was great because then you could get doctor pay for a little bit while you were resident. Because residents, I mean, as a med student, you're borrowing money the whole way.
Oh, most of the time.
Unless you're literally from a wealthy family, you're borrowing money all the way through resident. And the amount of money that it is now is a little bit bizarro. Like the cheap medical schools are like $40,000 a year.
Right, even in-state, in-resident, you're a resident in-state.
It's like $40,000 a year. And if you're going to a state school as an out-of-state resident, sometimes it's like $70,000, $80,000 a year.
Easy.
And if you're going to places that are like big name private schools, you're looking at, $70,000, $80,000 a year.
Yeah.
And that's just tuition. And that doesn't even pay for your apartment and your food and your living, right? So then most people who are because being a medical student is a full-time job. I mean, you can't also work another job and be a successful medical student. So most people borrow additional money beyond their tuition to live on, to pay for their rent and their food and their whatever. And it makes for a relatively meager living on borrowed money. And most people graduate from medical school with hundreds of thousands, like at least $200,000 up to $500,000 debt from medical education. Training.
I'll never forget 1983, 84, I was applying to medical schools. I remember there were a couple, I'll name them, in Washington, D.C. There was Georgetown and George Washington. You had to have $22,000 cash in their hands before they would let you into the school, into the first day of class. That was a lot of money back then.
Oh, yeah.
That had to be collected, and not as though it's coming or I'll give you an installment. No. Georgetown, Georgia, they wanted $22,000 received before you could sit down in class.
That's amazing. And then, so I mean, it's not gotten any better, and it's still tremendously expensive.
Yeah, and I know dental school's even more expensive. They have their own problems. Yeah, dental students graduate with $500,000 in debt all the time right now. That's my understanding.
So, once you've got all that debt hanging over your head, you better match. Because or else you don't match. I mean, what are you going to do? You're going to have the government gives you a 6-month grace period after you finish residency before you start making payments on your money, on your loans. So you have to have an income in order to start making payments on your loans. And you can go into deferment, but then it just accumulates and gets bigger and bigger.
So you don't become a rich doctor all of a sudden. You
not for a long time. You have to dig out of the hole.
Dig out of a hole. Yeah. So like when I was a fellow and I needed money, I was moonlighting. So I'd have to take call as a fellow in my official position. But any other night, I wasn't on call. I was working in the inner city. So I was like never sleeping.
Right.
For years, I was never sleeping. There's little cat naps here and there.
And because of stuff like that, that's where the 80-hour work limit came into existence. So now the government mandates that residency training programs cannot produce schedules that have their residents working for more than 80 hours a week, which is a pretty insane total amount of work. Anyway, but the point is that requirement came into existence because people were routinely working a lot more than that.
That's right. And as a medical student, the general surgery residents would tell you, you know what sucks about being on call every other night? You miss half the good cases. Right. So a real anal retentive general surgery resident wanted to be there all the time.
Right. I mean, those people had no life. I mean, nothing else. I mean, that's all you did, and it's literally like a calling where you don't.
It's a calling.
And nowadays, but with an 80-hour work limit. Or an 80-hour work week, you can have a family. You don't spend a lot of time with them and do fun extra stuff, but I mean, you can still like go home and sleep in your bed and see your spouse, and
it's a little more sane.
It's a little less crazy, but that's your clinical obligations is for 80 hours a week most of the time. But then you also have to study. Because you have exams you have to pass.
Oh, yeah.
And you have to read up and know, and you have to learn through these. I mean, surgery textbooks are like this. I mean, you have to learn through these books. And that's not happening while you're in the hospital doing clinical care. You have to do that after you go home. Right? And you're expected to read papers and be up to. So, I mean, there's lots of. You may have 80-hour work week that's your clinical work, but you also have to be, your educational effort is in addition to that.
Yeah, I don't think people understand this. It never stops. And even once you're in practice, you got to continue recertifying and studying. Yes. It really is a calling.
And then, so far in our discussion, we've made it into residency. Okay, so
now we're a resident. Okay,
now we're in residency. Okay, so we made it into residency. Residency typically has an intern year, which is really just a word for your first year in residency. And interns are protected in special ways where they're not asked to work more than 16 hours at a time. By the ACGME, those are the rules.
Used to be 36, but anyway.
So once you become a second year resident, you can work 36 hours. But as an intern, or is it not 36? It's only
less than it used to be.
I think it's less than that. But the interns can only do, I think, 16 hours a time, and then they get to go home. So that instituted the requirement for the night float system, which is a whole other discussion. You can talk about it, but essentially, your intern year typically is a lot of like learning how the hospital and how the clinical practice really works. Like, how do you write notes? What should be in my note? How do I write orders? What should be in my orders? How do I actually the nuts and bolts of taking care of patients?
You're starting to spread your wings, finding out what it's like to be a real doctor.
And you basically get. The interns get a lot of supervision over everything they do by their senior residents, and as well as the attending physicians who are over them, watch over them very carefully.
And historically, the attendings weren't there at all in the old days.
Yes, and that's totally not the case anymore.
Yeah, it used to be the chief resident was the chief resident. Right. You had and that was the person who managed the service.
Right. Yeah. But that's not how things work anymore. And even in big academic centers at this time, the attending physicians are sort of there with making the clinical or sort of the way it works is that the junior resident, like usually what happens is that the medical student goes in to see the patient first. The medical student tries to come up with some useful idea, but they're so they don't know enough to get a correct diagnosis or a correct treatment plan most of the time. So the medical student tries, and they kind of get educated about how they failed. The intern goes in next, and they've got a little bit of work that's been done by the medical student they can build on. And they try to achieve a diagnosis and make a reasonable treatment strategy for the patient. And they present that to the next level residents. And the residents there will usually advise them. And then the final decision before it actually happens is supervised by the attending, who says, yes, you guys have an accurate diagnosis. Your treatment strategy is good. Go ahead with that. And for patients who are in an academic center, they have to be willing to understand that this is the process they're going to go through their patient
care.
The
coats go from short to long.
Right.
And the hair goes from brown to gray.
Right. And it's this like that there's going to be these people coming in and talking to you who are going to try to tell you what your diagnosis is, and they're going to try to tell you what should be done about it. But they're going to be reasonable likelihood that they're not going to be accurate. And then as additional layers of training come in and more experience comes on board, eventually a board certified supervising physician will be involved in the final decision making about what needs to happen and what really is your diagnosis. But anyway, that's what happens for the patients as they traverse through the training program.
This doctor in training reaches their final year of residency, be it 3 years in or 7 years in.
Yep.
Now they got to start thinking about, gee, what's the next step? Where can I actually go and practice?
So there's several different things they need to do as they finish their residency. So every year in residency, they're typically taking some kind of in-service exam that's administered by the board of their specialty. So surgery has its in-service exams, and family medicine have their in-service exams.
Sure.
And residents have to take these exams as they move along. And these are basically trying to get the pulse of, are you learning what you need to know, and are you going to be a reasonably good person as a physician when you graduate? And they also typically have some kind of logs that they have to have done and maintain about how many patients have they seen, have they had enough patient encounters.
In my case, it was number of hysterectomies, number of deliveries.
Yes, right. So you have to complete these minimum obligations, and in surgery, it's a lot of operations. Then you have to do a certain number of this and a certain number of that to meet these minimum things, and you have to satisfy all of these requirements. And then you finish the training program, and if it's a good training program, they've educated you along the way, that you've passed your examinations up to that point. And then typically, we also skipped board step 3. Usually happens at the end of 3rd year, and that's the main national board for all doctors at the end of the first year of internship. That is typically the last requirement to be allowed to actually get a license to practice medicine in most
states. 1 or 2 years into residency.
You take board step 3, and you don't actually have to be finished in your specialty to get a license. You can get a license after you've taken board step 3. And then once you have a license from the state after board step 3, you can actually practice and get paid as a doctor.
You can moonlight or whatever,
But so that a person who's practicing as a clinician has at least finished board step 3 and gotten a privilege from the state to be certified in their state to practice.
Yeah, in my residency, my OBGYN residency, it was a big deal if you didn't pass that test. They wanted you to be a licensed doctor by the time you were 3rd year.
Yeah. And so then that's at least at 1 year of internship finished before you can take that test. And then, somewhere along the way before you finish your residency, you have to take that test and finish. And then most people will actually get a job offer and go to a place where they start their job before they have taken their full board exam for their specialty.
Yeah.
Because the board specialty exam is an additional pretty hefty exam that you have to take, and they only offer it like a couple times a year.
Right.
And depending on the details of the calendar and when you finished and when the test is available and when your job starts, oftentimes people will begin their first job as board eligible.
Right.
They're not actually board certified, but they're board eligible, meaning they've finished their training program and they're allowed to take the test, but they just haven't done it yet.
And they're on track. and let people know that if you've got a young physician, they're not too gray yet, they've still got a lot of pep in their step. If they're board eligible, that's wonderful. That's wonderful.
And that is, the safety net here is that the state medical board, who gives you the privilege to practice in their state and allowed to, charge people money to provide medical care without breaking the law, they carry the responsibility of making sure that if they're going to give you this privilege, you've had an adequate training. So you have to submit this huge past stack of papers.
So if you're
to the
board
state.
eligible, you're a fully licensed physician.
Yes, you can be.
And you can be. Most are. And if you're board eligible, it means you're young and smart, and you're in the middle of training, and you in fact might be smarter than the old person, the old doctor. Yeah.
Sure.
So don't turn away a physician if they say they're just board eligible. Nothing magic happens once you're board certified. It's once you're in that board eligible track, you tend to be.
Yes.
On
Almost
the
everybody
right
who becomes board eligible will subsequently become board certified.
Yeah,
very few people who will fall out because they failed to take, they failed their exams and then they couldn't become board certified. And those people, if that should ever happen, I mean, those people usually won't be able to get a job. The hospital that they would work for or the state will find out that you have attempted and failed to pass your exams, and they will not give you a license to practice in their state.
And you can take them a couple times. I mean, as long as you're staying, it's not a do or die. But eventually, most like now, if you're applying to a job, right? They'll say your contract is contingent upon you at least eventually becoming board certified.
Board certified, right? And like my contract at Boone, for example, says that if I don't maintain my board certification, I'm fired.
And that's beyond. So now you're board certified, and nowadays you can't be grandfathered. You got to keep taking and maintaining certification. So let's talk about that the final thing that people may not appreciate.
Yeah, I mean,
even once you're board certified, and by the way, I am double board certified. I had to be board certified in OBGYN, then reproductive endocrinology. We had Dr. Iliff here the other day. She's board certified in internal medicine and oncology and hematology.
Wow.
So
that's a ton of work.
It's a ton of work.
And each of these boards require a certain number of hours per year of what we call CME, which is continuing medical education. So you have to continue to be involved in some effort to try and make sure you're up to date on modern treatment strategies for the diseases that are appropriate for your specialty. And that's should be represented in your CME that you submit, right? And then they will have examinations that you take every so often. And there's some, depending on which specialty it is, there's different schedules.
Right.
And some of them are like little exams every year, and some of them have a big exam every 5 years or whatever. But you have to maintain this certification in order to maintain your board certification. So people who are interested, patients who really want to make sure, they can actually go to the board's website, and they can find out if a particular person has a board certification and if it's active. And
there's a place OBGYN. You type in Wilshire, you type in Gerber, general surgery, it's going to come up. Yep, boarded,
and the
active,
state,
in good standing.
In good standing. And the state will maintain also similarly for the state's certification to, license to practice in the state. So every state that you might be licensed to practice in will, you can search for Wilshire and find out that you have a license to practice in the state of Missouri, and that it's an active license. It's been maintained appropriately.
There it is. With the internet and whatnot, all the states are all linked together now. National databases, all that stuff.
It's one thing if you've got a person who is not. So anybody who's going to be giving you medical advice should have an active and good state license. And if you find a provider who's offering you medical advice that doesn't have a license to practice in the state, you should be really careful about paying attention to what they're telling you, because that is a big red flag. I mean, it's technically illegal to offer medical advice and charge people money for medical advice if you don't have a license to practice in the state.
Yeah, and that gets me thinking. You see these ads on TV for, let's say, male, or I'll say it, erectile dysfunction medicine. Say, hey, just give us a call. And they're doing it for weight loss drugs as well. Or, hey, just give us a call, and our licensed provider will they check some boxes, and I'm sure they're just skating on the thinnest of the minimum requirements needed to write a prescription in that state. Yeah. And they're certainly not seeing you in person making these decisions. So let's wrap this up now. We have advanced practice providers who do great work, but they are always working under the supervision of a physician, aren't they?
So it really depends on the details of. So they always have a collaborating physician.
Okay, there you go. Collaborating.
And the collaborating physician. There are different requirements in different states, my understanding is. And the collaborating physicians doesn't necessarily like it's like, it's not the same as a resident attending relationship. Okay, so a resident attending relationship means that like every patient seen by a trainee, a resident, is going to be seen by an attending who's going to make an evaluation of their diagnosis and treatment strategy as appropriate for every patient. Okay, for licensed advanced practice specialists, typically there is a relationship where some fraction of the patients are surveilled by the attending physicians.
Yeah.
Or then I guess it's not even attending, it's the supervising or associated physician with that person. So not it would be perfectly reasonable for a nurse practitioner or a PA to see some of the patients and make their own decisions about what that patient needs and diagnose them with problems and suggest treatment strategies and so on, without even talking to a physician about that. And that whether or not that happens or how that happens will vary to a great extent on what specialty you're in and what the relationship is between the supervising physician and the APP.
APP is
The advanced practice
provider.
It's usually a PA or a nurse practitioner or somebody like that. So, in some instances, the APPs have more autonomy, and in others, it's they're more closely aligned and they work together with their supervising physicians more closely for all of their patients. So, yeah, therein it gets a little bit uncertain at a policy level as to what actually has to happen compared to what actually happens on a daily basis with the patients.
Well, fantastic. Well, Ben, I think you've taken us through the whole spectrum, the arc of the training. Realize it never stops until I guess you fully retire.
Until you retire, yeah.
Until you retire. I think
let me ask you a quick question before we close.
Please.
During the course of your training and fellowship and stuff like that, just kind of rough estimate, how many thousands of patient encounters do you think you saw?
Oh my God. Oh, I don't even know if I could tell you. It's certainly in the thousands, I would think.
So I guess here's another similar sort of thing. Like, you had to keep track of all of your surgeries that you did.
Yep.
Do you remember ballpark-ish how many operations you had to do?
Oh, for residency, oh my God. I think we had to have at least 40 of this type of hysterectomy and 80 of this type and so many laparoscopies and whatnot. It was certainly in the low hundreds, I think. Yeah. I think, but I could be totally not remembering.
Yeah, I asked this because I kind of somebody had prompted me to think about this, and I had to figure it out for somebody a couple of years ago. And the number that I came up with seemed reasonable enough at the time, but pretty staggering. So in surgery residency, we work essentially 6 days a week, 50 weeks a year. So that's 300 days a year that you're working.
Right.
And it's 5 years. So that's, 1,500 days. Okay. And my estimate is that our services, because we had several different surgeries rotate around on, and some of them were a lot larger than others, but the average census across the whole hospital was probably 30 patients per service.
Okay.
So every day I would go in and I would see probably 30 patients. And I didn't write all those notes. Sometimes the other person would write the note, but our team would go by. We would see.
And you were learning from
it. We had 30 patient encounters every day for 1,500 days.
I think that's 45,000. I just did the math.
45,000 patient encounters during the course of my residency training program. And then, during that time, we had to log our surgeries, right?
Right.
So my surgery residency program, I did about 1,600 operations that I logged in my case log. It was 1,600. Right. So that means that there was 1,600 surgeries of various kinds that I was involved in with the supervision.
You were in there to some degree.
I was doing some sort of part. I didn't log it unless I did some part of the surgery. If I just stood over there and watched, I didn't get to log it. But if I actually did some part of the operation, sometimes the attending would take over because I wasn't moving it, I wasn't getting it done right, or especially early on when you're learning.
Yeah, you're opening, you're closing. You're
doing some important aspects of the operation. I would start the dissection. This one's really hard. Would you take over? And then that kind of thing. So, but I logged 1,600 operations during the course of my 5 years of residency, and then Since then, essentially every year of my practice, since starting in the summer of 2016, so now it's been what? Going on 8 years now?
Yeah.
I've done about 400 to 500 operations every year.
Right. So a few thousand or more.
So about, somewhere
Where
around...
you were the fully responsible.
Right. Well, there's nobody else in the room. It's just me.
You're the surgeon.
So, I mean, that's kind of just to give people a sense of like, at least in surgery, this is the volume of supervised medical care that you have to finish through before you get the privilege of being allowed to become a board eligible doctor. Right. To be a board eligible surgeon, you're going to see, maybe my residency was a little bit heavier, busier than some others, but you're going to see probably 20,000 minimum patient encounters with somebody supervising you through that patient encounter. And you're going to do at least 1,000 operations with somebody supervising you through that operation before you get to become a board eligible general surgeon. And then once you become a board eligible general surgeon, then it just takes off. I mean, you continue to do the same
and we get better.
Staggering volume of patient encounters and actual operations.
And in some specialties, I really don't want to name them. When you get somebody freshly minted board eligible, the attendings still say, hey, they're going to need another year or two till they're really ready to fly solo.
Right, and that's perfectly. I mean, and that's why, to a certain extent, I think why there has been an expansion of fellowships. Because fellowships are one of these ways in which people can sort of have additional supervision when they're out, they're qualified to be a doctor, but they can have additional supervision for another little while. General surgery has had a lot of expansion of fellowships out of general surgery. They're much smaller fraction of general surgery residency graduates go directly into practice from graduation now than it used to be. The vast majority of them, like more than 80% now, go on to do some kind of fellowship.
Advanced subspecialty training. Well, Ben, thank you for a fascinating discussion. Thanks for letting me in on the changes that have occurred since I graduated.
Yeah.
And it's reassuring to know we're all trudging the same road and all working to always improve and becoming the best physician we can be and providing the best care for our patients. And hopefully our patients now can better discern who is speaking from what position, who has the most experience to give them the best medical advice.
Absolutely.
Thanks
for
again,
having me.
Ben.
It was wonderful. Fun.